Give everybody a little bit of time. Hi, everyone. As you guys are trickling in, we'll just sit here and watch your faces pop up. If you have any troubles, please put it in the chat. And we'll get started in about 30 more seconds. Give people a chance to connect to audio. I see a lot of bouncing dots as people are connecting. Welcome, welcome. So happy to see you all. People are still trickling in, so we'll take that. All right, well, let's go ahead and get started. I think we're starting to plateau a little bit. Good afternoon. My name is Katie Defford Melendez, and I'm the Manager of State Affairs at the National Head Start Association. I want to welcome you to today's session, and this is, gosh, at this point, I think our third or our fourth in our 2023 Early Head Start Rising series. And from the beginning, Head Start has not only kept up with current trends, but it's introduced new and bold ideas into the broader early learning community. And her Early Head Start especially is a model for the very best and most innovative in child and family services. At some point during today, I'd really like us to open up the lines and learn more about what you all do in your world. But to continue on with this current learning series, it honors our drive to learn and introduce and also incorporate the best new evidence-based practices and ideas into our work. We've got different webinars that focus on advocacy and best practices. They run from June through December, so just kind of keep your eye on the space as you learned about this particular one. You'll see about others coming in the future. And we'll talk about things, pay parity. Today we're talking about services to pregnant people. We'll also talk about child welfare systems, expanding state funding, and then also bring you guest speakers from organizations such as the National Black Child Development Institute, 0 to 3, and Unidos US. But today, we're excited to discuss how early Head Start programs serve expectant families. We'll be joined by two programs serving families on each coast. The Neighborhood House Association in San Diego, California, serves families from pregnancy all the way through senior care services through their continuum care model. The Episcopal Children's Services provides programs to children and families in 14 counties in Northeast and Central Florida, covering a really large geographical area for those of you familiar with Florida. And both of these programs' commitment and thoughtful models, we hope will resonate with you and inspire you. So before we get into a little bit more about the kinds of services that we can provide pregnant people and expectant families, I'd like to hear a little bit about you. We're going to launch our very first poll just to find out who's in the room. So if you all will get a chance, the poll should start. Courtney, let me know if you need me to launch it. I know in the last one we did, it got kind of wonky.
It says it's launched and we have one so far.
Okay, great. I can't see them. So Courtney, I'm going to let you.
All right. Looking for some participation. Who's in the room today?
Can you all see the poll?
I can see it. It's exciting to see home visitors.
Again, I can't see. I want to know
and
about
everybody
the
else
excitement.
and everyone else too. Let me counter that with I'm excited to see everybody.
We were just having a discussion before everybody came in about home visitors and what a special place they have. So that's probably why. And nurses, my mom was a nurse for 30 plus years.
Wow.
Not a job I could do. Family service and health manager, great.
Thank you for sharing in the chat if you didn't see yours represented here.
Program nurse in Ocean County in New Jersey. I was born in Bayville.
All right, it looks like our participation has waned a little bit, but our home visitors are showing up with 58%. followed by our education curriculum coordinators at 25%, and early Head Start directors at 17%, plus all of our nurses, health specialists, and everybody who has chimed in the chat. Thank you. Great to have you here.
Given that, I'm going to jump into one more poll, and I'm sorry because it'll help us to kind of tailor some of our conversations. But given that, I think we're going to know the answer to this next one. But I'm curious about, do you or your program currently serve expectant families? So we will load that poll, and then I promise we'll get into actually the meat of it. But do you currently serve expectant families, or are you considering it? We were having a conversation about expanding early Head Start services, and how do people decide to include pregnant people into that service delivery plan? Or is it something that you're actively seeking to expand in your program? So I think Courtney is loading that one. Again, I can't see for some reason.
Yeah, we have a good percentage participating now, and with an overwhelming answer of 86% with yes. Followed by pretty much a tie between no, considering, and actively seeking to expand services. So, and if something different, add it in the chat, please.
And I saw that Sharon said that they're working on it. So hopefully today will give you some good ideas, Sharon, and that, we're going to open it up to the speakers in a little bit, and you'll be able to ask questions from them. So I'm going to go through a little bit of the numbers, and one of the reasons why I was really excited to see that 86% or hear that 86%, since I can't see it, is when I pulled the PIR numbers for early Head Start, I found or saw that we serve across the nation less than 13,000 pregnant people in our early Head Start programs, less than 13,000 pregnant people. And in this space, in early Head Start, we often say, the need is far greater than the capacity. I can't tell you how many times I've said that, because it's absolutely true. But when we discuss early Head Start services to pregnant people, there's simply not enough home visitors, early Head Start slots, and funding, right? Funding is what makes a lot of this work happen. And with our recent Supreme Court decisions and current political climate, we know that the need for prenatal service is great, and it's just getting greater. And this is an urgent issue for us right now. And without intervention and advocacy, more mothers will be at risk and more children's health will be compromised. We know that prenatal care reduces risk of complications for mothers and babies. We know that expectant parents experiencing poverty are at a risk of multiple health issues, including malnutrition, obesity, diabetes, and heart disease. We also know that prenatal care reduces the risk of preterm delivery, preeclampsia, eclampsia, gestational diabetes. And then one other aspect to this that we've really been trying to dig into at NHSA this past 6 months is the maternal mental health. We know that mental health symptoms impact 1 in 5 perinatal women. And also, finally, we know that there is a disproportionate impact on women of color. And so what can we do? What do we do? We know that there are proven programs. We know that early Head Start is one of them. And when I looked again at the PIR data and how we served expectant mothers through early Head Start, 92% of pregnant early Head Start mothers received prenatal care. 88% had health insurance. 71% received postpartum health care. 40% received professional oral health assessments, examinations, and treatment, and 32% received mental health interventions. So that is up from 30% last year. And across the board for women with maternal mental health symptoms, typically only about 20% receive any kind of intervention. So we are doing good work. It's not quite there, but we're getting there. Thanks to a lot of the work that you all do. Apparently 86% of you on here, which is phenomenal. And in addition to healthcare, there's a lot of educational services provided. 85% of pregnant early Head Start mothers received education on fetal development, the benefits and importance of breastfeeding, and also nutrition. 82% received information on infant care and safe sleep practices, and also the risks of alcohol, drug abuse, and smoking. So we know that early Head Start services positively impact families. And so just a quick overview of what kinds of services are provided. The specific services are dependent on the community assessment and the resulting program approach. We also know that understanding other organizations in your community and the agencies that are providing services to families so that they're not duplicated, but supplemented with each other, and they work together. So Early Head Start has to facilitate ongoing healthcare and insurance as appropriate, and then comprehensive services. So we'll talk in a minute through our amazing examples coming up about what that comprehensive service looks like. But that's something I'd like you to think about throughout the rest of the session is what do comprehensive services to pregnant people and expectant families look like? Early Head Start requires that you provide newborn visits within 2 weeks and then provide prenatal and postpartum services such as fetal development information. Maria just had a really interesting story. We'll talk to Maria in a minute about those postpartum, working with families and teaching them basically all the care of children, but also nutrition and all the risks that we just spoke about drugs and smoking, and but also labor and delivery and postpartum depression and safe sleep, all those things. So while Early Head Start works hard to serve pregnant people, if we really want to serve our expectant families and hold them in the center of the work, we really need to consider what those comprehensive services look like. So with that, I would like to introduce our guest speakers today, Kim Skirty and Maria Luna, and also Kim Flowers. I'm going to put them all together at once. They represent 2 programs who are working to provide comprehensive services to expectant families through our Early Head Start and also their collaborating agencies. Kim Skirty and Maria Luna work for Episcopal Children's Services in Florida. Kim is the Director of Home-Based Services and Maria is the Home-Based Service Manager. So I'm going to start with them if that's okay. And then we'll also get into Kim Flowers, who is the Senior Director of Family Support Services at the Neighborhood House Association in San Diego. But let's go ahead and start over in Florida. And Kim and Maria, can you give us an overview of your program and how it impacts our families?
Hi, yes, I'll go ahead and start. I'm really very, very excited to be here today to talk anything home visiting and services to pregnant women. We know that the majority of the Head Start and Early Head Start slots are directed towards our center-based option, but home-based is so important. It does take a special person to be a home visitor, and I'm just so thrilled that we get to just have one whole hour to like converse solely on that, because all the things that Kim said, all the stats that she just reported to us, they just remind us of the importance of the work that we do, just the paramount importance. But I've been privileged to work for Episcopal Children's Services for the last going on 22 years now, so it's been quite a while. I started out in social services, but like a lot of you, I just had this burning desire and love for children and wanting to see them and do anything I can to work with them to achieve and succeed. And so I made my way from victim services and domestic violence and a lot of the other things that I did, juvenile probation, and moved towards early education, which has just been absolutely my passion and my love, and my coworkers and the people I've met along the way have just been amazing. But ECS is the second largest nonprofit in the state of Florida. We do cover, you said 14, you might be right. I'm like, gosh, I thought it was 13 counties, 12 of which we provide home-based services. So that's quite a large area of Florida, just as Kim said. We cover Alachua, Baker, Bradford, Citrus, Clay, Dixie, Gilchrist, Levy, Marion, and Nassau. And our biggest, obviously, is Duval, the Jacksonville area, which is a very large county. So it's been a bit of a challenge and a passion to provide and to spread those services through all those different areas. A lot of the information that Maria and I are going to share is not earth-shattering if you're an Early Head Start program, because we have the performance standards. They tell us what we're supposed to do and what services we're supposed to provide. But we do, you do kind of tailor the options a little bit based on the area you serve. So we do have the flexibility to do a little bit of that. But obviously, our home visitors, we cover all those counties, and they have a caseload of 10 each. We're trying to gear towards quality. We did at some point have them serve a little bit more. I guess there's a range we're allowed to do, 10 to 12, but we felt if we really wanted to achieve quality services that we needed to keep it at that 10 cap. We do everything, again, that's nothing earth shattering. It's probably what you all do too in your own programs. If we have a lot of home visitors on here, parents are their child's first and best teacher. We really tout that. We utilize curriculum, the Partners for a Healthy Baby curriculum, and create lesson plans on a weekly basis, working with their children. We provide support so that they can nurture their child's healthy development. We reach families where they are by working with them in their home. And just like we've already said, and it just really takes a special person to be able to form those bonds and those relationships, and to be able to do that. And we just did our second round of HOVERS for the year. We do the home visitor observation scale to provide feedback to our home visitors. And that's the highlight of the year for me, is to actually participate in that, to actually go into the homes with our home visitors and see their relationships. Because I said earlier, I said they're family with their families, and they really are. They go in there and they are welcomed like families, like the families are trying to feed them and give them things, and they hug them, and there's a lot of, you can just feel the love when you go. And so that's like the greatest gift I can have. And again, that comprehensive services piece, we provide education, health, disability services, nutrition services, and family services. We're a large organization, so we're really blessed to have a lot of the different components in-house, and then we can refer out and rely on community partners where we may not have that stuff. And what services look specifically when somebody signs on for ECS home-based services. I'm going to turn this over to Maria to kind of talk to you guys about that.
Hey everyone, I'm Maria. Again, I'm with Episcopal as well. I've been a home-based manager for about 5 years, and I was a home visitor before that for about 5 years as well. So I do have some of the experience that you guys are having. I do miss home visiting quite a bit. I enjoy having that one-on-one relationship that you get with the families, rather than when you're in the center and you have a lot of different families. So it gets to be a lot of, in a way, I guess, kind of personal relationship that you kind of have to build, along with it being professional, keeping always that boundary with the families. So what can they expect from our program? So we have 90-minute home visits once a week. We utilize the research-based curriculum for all of our lesson plannings, along with planning with the parent. All of the lesson plans, all the socializations, everything is planned with the parent and involved. We support the parent-child activities that will enhance their interactions and their child development. We do support for setting and achieving individual and family goals. We assist with completing developmental screening. So we do the ASQ screening, the ages and stages questionnaires. We do the one with the different developmental domains, and then we also do the social emotional one as well. And then we also do the DRDP, oh gosh, Kim, you might have to help me, the developmental
desired results developmental,
that one.
DRDP profile.
It's through we do it through Child Plus. I always get tied up with the DRDP meeting, but we utilize that with our children. And then we also do the group socializations, which is typically twice a month. Those are planned with the families as well. And then a lot of what we ultimately do as well is sharing of resources and referrals to outside agencies. And then some of the services that we provide to pregnant women. So we start our services through the application process. So during our application process, we start asking them different things just to kind of get a background on the families, whether they've completed high school, if they have a job, is it both parents or only one parent? Are they homeless, foster children, any kind of information that we can get a quick overview of what's going on with the family. From there, once they've been accepted into our program, then we do our enrollment visit. Typically, our first enrollment visit is where we complete our prenatal screening and our prenatal verification. So our prenatal screening is just a screening that lets us look into their health history, any past pregnancies that they've had, any nutritional problems or lack of nutritional needs that they may have. If they don't have a health home, then we try to get them connected through Medicaid if need be, or whoever it might be. If they don't have a dental home, then we try to obtain a dental home as well for them. And we try to do this within that actual visit, not like we go back into the office and do it. No, we try to do it all in the visit. We try to have the parent, okay, if you, this is what you're missing, let's look real quick where we can get you services. And then we try to have the parent be the one to make those phone calls. And then we're just kind of there for more support. And then the prenatal verification is just letting us know, kind of verifying that they are receiving those health services from the very beginning. And then typically our second and third visits with the expectant families is that we do a family needs assessment. So the family needs assessment just lets us know, gives us a deeper look into the family as a whole. So we look at discipline, we look at their food, at jobs, the safety of the home. So there's a lot of different aspects that we look in there, and even in through the community. And then when we're once we have the ball rolling and we're visiting the families on a weekly basis, then we do the lesson planning. We do the lesson planning with them, but then we also do, in our lesson plan, it's broken down into different areas. And one of them is the purpose of the visit. So before we go, we always try to plan for that purpose of the visit before we visit with the family, to try to get more details as to what the family expects from us and what they want to do. Then we do the sharing of resources, and then we also cover the educational components that are required by Head Start. So the fetal development, the risk of alcohol, smoking, all of those. And then one big component that we have for our expectant families is that we provide comprehensive services. The way we do that is we have different specialists. So we have a social emotional specialist, a nutrition specialist, and we have health specialists. Our social emotional specialists, there's licensed clinical social workers, and they're able to assist us in case we have a family that has any kind of mental health related concerns or issues going on. So with our expectant families, once the mom has had the baby, we do what's called the Edinburgh screening, depression screening. And we do that at 2 weeks, 1 month, 2 months, 4 months, and 6 months. And we also do it on any child that enrolls in any of our programs that is 6 months or younger. For our 2-week visit, which is the one that's required by Head Start, we do the postnatal screening there. And we also do the Edinburgh screening. And then the social emotional specialist is there with us in case there are any kind of red flags that kind of go with once they have completed the screening. But then we also have them basically kind of on call for whenever we do all the follow-ups on this Edinburgh screening. Then for the nutrition specialist, they just basically make sure that they are getting adequate nutrition, especially during their pregnancy, because we know how important that is for the mom and for the baby. And then they help us address any nutritional needs that they may have, whether that be referring them to a food bank or just really looking more in depth because the mom isn't, during the prenatal screening, they show that they're not really eating any, vegetables per se, or they're drinking too much caffeine. And then we have the health specialists that help us make sure that they have a dental home, especially when we sometimes run into issues like the doctors aren't kind of listening to what we need from them and what the parent needs. So we get our health specialists kind of involved to help us kind of resolve any issues that we have. And they also help us find a dental home and a health home for the families. And then we have our home visitors. They're the main specialists in all of this. So they work directly with the parent. They make sure that they're receiving all that prenatal and postnatal education that the family needs. They ensure that they have a dental home and a health home. They have adequate space and infant items for when the baby comes home. They give them referrals to any outside agencies. They are there for all of it.
That is so much. Kim,
Yes.
I think I cut you off, Kim Skirty. I didn't mean to, but I didn't know if you were going to add to what Maria had said.
No, I wasn't going to add. I was just like, that was a great overview of all that we do, and just to really highlight the comprehensiveness of it for sure. Is that a word, Katie? Comprehensiveness?
It is now, right? If we spoke it, it's a word now. I was taken aback by all of the different experts that come in and coordinate to serve that one family. and how, again, comprehensive this is. We're going to go back to that word.
Yeah.
And then even I was digging to find that 800 number for the screenings for the mental health. There is an 800 number that if there aren't services in your community, it will start trying to connect you to people, even if it's through video and all that. So I'll find that while we're talking. Before we move on to the other coast, does anyone have any questions for Kim and Maria?
I see there's one question there. They talk about how many home visitors we have. We have 2 very large grants, and it's North Florida and Central Florida, and we have 8 home visitors for each grant. I know that sounds very little. They are spread pretty thin, but yes. So yeah.
And again, I don't know if I don't know if you all are familiar with Florida, but it's a pretty wide and long state. And so in Duval County, the city of Jacksonville is I'm going to see if I can get this right. It is the largest city in the nation as far as space. So the amount of distance that their home visitors, and I'm going to ask them about that in a little bit after we're done and we open up kind of a panel between the 3 of the programs, the 3 people in the programs, but it's a huge space. And then to serve these really rural areas. So I'm in Tallahassee, Florida. And I remember visiting a program in the Gateway Early Learning. And when someone was telling me, yeah, we've got 1 ambulance for like 3 counties, 2 or 3 counties, 1 ambulance. So if somebody's at a traffic stop and a woman goes into labor, you know, you better plan. So that said, I just think we'll talk more about the different space you guys for 8 home visitors, that's, 80 families that you're serving in a very large space. So we'll talk about that in a minute, but thank you guys so much. And
one last question.
Yeah, please.
Is there a specific curriculum you use with your pregnant families?
Yeah,
yes.
We use Partners for a Healthy Baby is the curriculum out of FSU, CEIP. We utilize that. It's very comprehensive, very easy to follow, very easy to use curriculum. I highly recommend. Should I do that? I highly recommend. It's out of FSU. I'm an FSU graduate. I have to highly recommend anything from FSU.
And that crew out of there is amazing. Mimi Graham, if you guys haven't heard that name, you should Google her. She's phenomenal. She does a lot of restorative justice and social emotional care for families. Like she's got her hands in everything, especially if it's related to families. So I can see why you chose that, Kim and Maria. Okay, so Kim Flowers, you're up. I'm excited to hear about you. So you'll hear a different program. She's in San Diego, California, another very large city. So anyway, I have all these questions, but I'm going to hold them. I'm going to hold them to the end. But please tell us more about your neighborhood community program.
Absolutely. So first of all, thank you for having me. It's exciting to be here and to be a part of a conversation in which we're learning about each other's programs. And I almost could have said ditto, ditto, ditto to a lot. So I'll try to think about what I can share that would augment or supplement what our esteemed colleagues, Kim and Maria, have already shared. So coming to you from San Diego, I wish I could tell y'all that the sun was shining today. It's morning, mid-morning here. It's a little bit cool and overcast, but still exciting to do the good work of home visitation. I'm a licensed clinical social worker, and I'm also endorsed in the state of California as an infant, family, early childhood, mental health reflective practice facilitator as a mentor. And that'll be important to know a little bit later in our conversation, I think, as we're talking about this important work that we all do together. Neighborhood House Association started in 1914. So we've got a long history here in San Diego County. We began as a refugee resettlement house. If anyone's familiar with Jane Addams' early work in addressing poverty and helping immigrants here locally, refugees, with transitioning to San Diego. So over 100 years later, we're a pretty robust program, still continuing that good work, having served over 3.5 million individuals in our community. And that, I'm really proud to say, includes 57 years of Head Start services. So we began with the inception of the program. We also are a very large program serving this incredibly beautiful, diverse community across 55 zip codes in our region. So our catchment or service area covers 55 zip codes. We're funded to serve over 6,500 children and families with both center-based and home-based program options. And we do that in conjunction with some delightful community partners, our subrecipients. All Kids Academy, Episcopal Community Services, National School District, Chicano Federation, and City, Mesa, and Grossmont community colleges. The area here geographically, it's a mixture. It's both urban and rural. Long stretches of beach all the way on down to the border, and then we start moving inland and it gets toasty and warm, and and things get a little bit more sparse out there, but it's a beautiful place to be. We're the second most populous of California's 58 counties, right? And we're the fifth largest county in the country in the United States. And when we look at our community needs assessment, which helps inform our work, when we use the US Census Bureau's diversity index, we're the 12th most diverse index in the state of California. So when you look at our stats, we're still predominantly white. People identify predominantly in terms of race and ethnicity as white alone, if you will. And then secondly, Hispanic and Latinos, not too far behind. So those are the two most prevalent racial and ethnic groups in our county. And then coming behind that, we have Asian and Native Alaskan and Pacific Islander groups. And then what we're seeing in terms of our demographic trends is more and more of a multiracial identification belonging to two or more groups. And so hold that in the back of your head that we're incredibly diverse. And then also pair that with the understanding that more than 1 in 5 San Diegans are foreign born, notwithstanding their immigration status. And then in our service area, 11 communities alone have the highest level of child poverty in the county, right? So we're serving, it's very interesting because we're an area that is incredibly affluent. There's a lot of money in San Diego. There's a great deal of folks who have high degrees of education. And then you pair that alongside with a stark reality that not everyone has the same kind of privilege, right? That there's poverty, and indeed there are deep pockets of poverty here in San Diego. And if you are foreign born and you speak a language other than English, you are more likely to live in one of those deep poverty pockets, which means that folks are struggling in some instances to meet the needs, basic needs for the care of their children. And so that paints kind of the picture of San Diego. And then there's a lot of ditto in terms of our program and the Episcopal Children's Services, but 888 of our over 6,500 home-based, over 6,500 children and families that we serve are home visitation slots, if you will. And of these 888, 114 are specific to what's called by our Office of Head Start as Services for Pregnant Women. We have recently renamed ourselves to be Services for Expectant Families so that we could increase outreach and inclusion for those who are non-binary in terms of their genders, and also who have diverse family structures. So we're thinking about our community needs assessment, the needs of our community, the makeup of our community. How can we be more inclusive, right? I think we're all working on that, hopefully, in lots of different ways. So 114 services for expectant families, families that are enrolled. Our primary curriculum is Parents as Teachers. And then we also utilize the March of Dimes, Becoming a Mom, Comenzando Bien curriculum, along with Florida State's Partners for a Healthy Baby Before Baby Arrives. We also augment with the Purple Period of Crying, which is an evidence-based curriculum. It's a prevention curriculum designed to prevent what's known as abusive head trauma, right? It used to be called shaken baby syndrome, but now abusive head trauma. We also screen our parents using we screen prenatally and also postnatally. I think our policies, our SOPs call for 4 to 6 weeks after the delivery of a baby. Using the Edinburgh postnatal depression screen, although our home visitors our beautiful, delightful, amazingly talented, wonderful home visitors, they may utilize the screener at any given time. So we teach our home visitors to look for red flags and symptoms, risk factors, if you will, and can augment the screening that we dictate in our SOPs. And we're looking at, I'll just add this here now, we're looking at transitioning to the PHQ-9, Patient Health Questionnaire, to screen for parental depression. And I think that also is aligned with our desire to be a more inclusive program, because we understand that dads and other partners experience depression and anxiety. So we're looking at the GAD-7 as well, the one of the I guess a global anxiety measure that comes from Pfizer, if you will. So we also screen. We recently trained all of our home visitors in perinatal mood and anxiety disorders, which is an area that I'm specialized in. And we just did a pilot with the Mothers and Babies program out of Northwestern University. And we're getting ready to implement across the board the Mothers and Babies evidence-based curriculum to address parental stress, anxiety, and depression. 2 of our perinatal home visitors are certified as lactation educators, and all of our home visitors are certified as infant massage educators. That's like a tongue twister. I'm not sure why, but it was for me. We hire our staff as often as we can to reflect the communities that we serve, right? So our home visitors speak various languages and come from the communities, although we're having a hard time, as I imagine many of you are, both in our home-based and our center-based options with staffing. There's been this tremendous shift since the pandemic, and filling our vacancies has been hard, and filling them in a targeted way where we're able to match to our communities, that even becomes just another layer of, I'm going to give a nonsensical word, another layer of difficultness or hardness, if you will.
Expanding lexicons here, Kim.
Thank
Both
you.
of you guys have given us some great words.
You guys have given permission for that, so thank you. We don't have to be perfect, right? And I'm glad to be a part of that crowd. I wanted to share that we contract with Tarjimly, which is an on-demand HIPAA secure interpretation service. So we have a hotline number for our organization, and within a couple of moments, we have access to an interpreter as needed. And then for in-person interpretation, we utilize a local company called Translation Solutions. I'm not sure if they're national, so I'm dropping their name just in case. Our staff are also trained in motivational interviewing and in the PWE model, which is important to me because, and we as panel facilitators here today, I'm going to pull back the veil just a little bit, but we've had conversations about how important it is to approach services in a way that we're facilitating, we're partnering, we're honoring strengths and culture, right? And so the models of motivational interviewing and parents interacting with infants help support our staff in doing that, right? We step out of the non-expert role and come alongside and build on the strengths that families have and share our expertise and knowledge as it is welcomed and appropriate, and in manners I hope that are very honoring and relational. So we have 3 licensed mental health clinicians on our team. I'm one of those 3. We have an electronic service request portal where field staff, either as a result of a parent or an expectant parent's request and or conversations, observations that folks have and conversations that ensue, can access services, whether they're mental health services or any of those, education, health. We have registered dietitian, right? Like any of those comprehensive services can be accessed through our service request portal, and or people can just reach out. It's like no door is the wrong door to access our services. We have a central kitchen because, and I'm naming that aloud because our central kitchen produces scratch meals that honor families' culture and dietary needs. And we make use of, in our home visitation program, we make use of that food during socializations and other parent meetings. And we assisted families during the pandemic with food as well, and diapers and all sorts of other things, as I'm sure many of you did. But I'm going to stop there because it's a lot of information to absorb from both of our organizations. So Katie, I'm going to hand the baton back to you and just see if there are questions or thoughts or places that you want to take us.
So I think everybody here can probably take themselves off mute or raise your hand. I do see there was one question in there. Is that portal available for, I'm assuming that's Maryland, or for MDs?
It's a great question. It's a portal that is our IT department developed that portal. So it's an electronic service request to tap into services within our organization. I wish I had a magic wand and I'd give it to you all. But it helps.
Do other agencies access that portal, like your collaborative agencies, or is it just within you all?
Yes, we do have. I have to stop and think about how that works. So they can access some components of our electronic database. We utilize Go Engage, which is CleverX. I think my colleagues here said that you all are using Child Plus. So we're on different platforms. And in some ways, the system that our IT department designed communicates with Go Engage, and our subrecipients can access Go Engage. And then also they can access us for supportive services. Our subrecipients, we monitor and support them as well. They're part of us. So when we have workshops and trainings and all sorts of things, or if they need supports around specific needs for their staff or children and families, expectant parents that they serve, we're happy to come alongside them. So they can also just pick up the phone or send an email, because we have those kinds of relationships, as well as put a formal request in.
And I think that is, let's see. Okay, so Sharon was asking about, I'm sorry, I'm reading the question. I think she says that she has to go, or how can she access? I think she ran before she could finish that. This recording, I believe, will be available. I will find out more. We'll make sure we get this. But so along that lines, I know that the collaboration is often hard, especially when you're sharing data. That's my personal experience between programs and all of the FERPAs and HIPAAs and the things. But Kim, I'm going to ask you this. When I first started exploring the different programs that serve pregnant people, and I found that continuum of care, I started considering the collaboration that you all must take place in your program between all the other agencies and organizations, and all the funding collaboration that has to happen to make sure you're supplementing, not supplanting. I have to use the right terminology there. And then when I spoke with you, you underscored the thoughtful communication between your programs. Can you tell us a little bit more about how you work together to provide these comprehensive services?
Thank you for that. So the continuum of care model is this beautiful model of having the ability to initiate services prenatally, which is what we've been talking about here today, and then over the course of the lifespan, all the way through those senior years, right? And so when you think about neighborhood house association, the way I think about neighborhood house association is that we have two kind of sides of our house, if you will. We have our early Head Start programs, and then we also have our social services programs. Black Infant Health, we have is one of those programs. We have a program for that's like a homework study club. We have college prep services. We have HIV services. We have services for those who have been incarcerated and who are re-entering into our community. We have mental health services, dual diagnosis services with mental health and substance abuse or addictions. We have senior day center. We have a senior center, a day adult health adult daycare health program. Like we have the whole gamut of the lifespan within our own agency, and even still we're not able to meet, of course, all of the needs that exist. So we partner extensively with community partners, in also doing the good work alongside in San Diego. So we're a part of this rich network or fabric, if you will. And I think that's critically important, because it's from there that we can help families to thrive and achieve their dreams and their hopes and goals. So internal referrals are pretty simple, right? We have we use a strengths and needs screening tool that, like Maria was mentioning, evaluates across 19 different domains of functioning within families. And then through that conjoint assessment process, families develop goals, and then we think about actionable steps to achieve those goals. And part of that includes the home visitors' support and check-in, and helping them to think about modifying where necessary, providing encouragement, etc., and then linking them to resources that are in our community. We have our Family Community Partnerships coordinator who sits in many community meetings and is at the table for important conversations. We have formal MOUs and MOAs with organizations, as I know many of you do, and then also informal partnerships. I think I could probably give you a list of over 150 organizations that we partner with here in San Diego. And a couple of, I think, key examples would be Child Welfare Services. We have a quarterly meeting with our program and other Head Start programs, because our county is so big. There are others that serve children and families as well. And we have an MOU that the protective services workers make direct referrals into our agency of those who are child welfare services involved. We also have a relationship with Rady Children's Hospital, who does all of the developmental screening and linkages to services and supports and treatment to those same children that are involved in child welfare services, so that they are making referrals as well, and we collaborate so that we're holding the families carefully, giving them the right amount of support that's needed in order for them to engage in our program or another program if need be. So that happens quarterly and is ongoing. And then I also sit in our Child Welfare Services Fetal Alcohol Spectrum Disorders work group, where a host of organizations from our community come together: probation, home visitation, family support, health, mental health, the school district, the regional center, so early intervention, etc. We're coming together to make a difference in preventing, identifying very early on, and treating through all of us partnering together, depending on what the child and family's needs are, this area of, in utero exposure to toxins, essentially. So I think we're active participants, and we're relationship based, right? In the same model, the same way home visitors are with families, we are relationally based in our community so that we can deliver the right services at the right time in the way that is needed most. And I'll pop this in the link for everyone, but we belong to an organization called the Family Support Connection Collaborative. The American Academy of Pediatrics is like the backbone organization, but home visitation programs and other programs that are serving families prenatally and up through age 5. So think mother to baby, doulas, our breastfeeding coalition, along with Nurse Family Partnership, Maternal Child Health, Healthy Families America programs, et cetera, all coming together. We used to have like old school referral pathways. We have like a flow chart diagrammed. This is who we connect families. This is the best home visiting program that we connect a family to based on their needs. We are coming into, what century are we in? The 22nd now, is that right? Is that right? I don't even know. I'm a social worker, not math. Anyhow, so the family support connection, we come together on a monthly basis and we share about our own programs. We bring in presenters, we kick around important initiatives or topics or challenges that we're having in the field. And we have a website together, which I think is pretty cool. Parents who are searching, there goes my camera, huh? Parents who are searching family support or home visitation services can locate this website. We're now looking at hiring someone to help us to market it. And they can fill out a simple questionnaire. Do they belong to a military family? Is this their first pregnancy? Has a healthcare professional told them that they have a high-risk pregnancy? Do they have a desire to stop using substances, or has someone supported them in thinking that they should be stopping to use substances? Like a whole host of questions. They can punch this in and receive information about our programs. The American Academy of Pediatrics just received a grant to hire an intake specialist for all of us, which would mean that that intake specialist would perform a universal assessment using the FROG assessment, which is the Healthy Families America assessment. But what it means for us is that when families are connected to our agencies, regardless of which agency we are, we'll have a universal intake. So we'll be able to see right from the get-go what the family's needs are and be able to respond to them in a much quicker way, and also in a way where the services are aligned to meet their needs. I'm going to pause because those are just examples of how being active and visible in the community and communicating and partnering. And I know all of you have, partnerships as well.
So I think in a separate meeting, we were discussing how some states are really trying to figure out that no wrong door policy, that no wrong, and where to kind of filter services to what needs best. So Kim Flowers, I think that's a whole nother session that I feel like you guys could provide some expertise on what that looks like. And this is my ignorance, but when I think of San Diego, I think of a huge city, clearly with the 50 plus zip codes. That was amazing. And then as I move back down to the East Coast, and I think about the different geographical areas and how you all coordinate. Okay, I'm also going to say, if those are not comprehensive services, I don't know what the definition would be. And so anyway, so as I move back down to the East Coast and I think about Jacksonville is a very big city. It has a lot of opportunities and services, but when you're moving, over towards Lake City and you're 70 miles out or a little bit further south to Central Florida, when you're in a lot of cow country and farm country, how do you all provide those comprehensive services in that area, Maria and Kim? Especially considering the vast, that's got to be a lot of driving and partnering and doing that across county lines as well. Could you talk a little bit about that?
I think you said it best. It is a lot of driving and partnering and collaborating. I mean, there's no magic to it. It is just really, the home visitors live, grow, work, and hopefully get a chance to play a little bit in the communities they serve. And so they know what the services are that are provided there. They know where to go when they need something. And I think we all recognize pre, post, and during pandemic, like the needs of our families are still the same. They still need assistance with food. They still need assistance with diapers. They still need assistance with housing. Like Jacksonville's just had a ridiculous rise in rent cost to the tune of $400, $500, $600 a month, which is probably nothing compared to San Diego. I know that the costs out in California are just ridiculous, but yeah, so there's just a tremendous amount of collaboration, just knowing who our partners are, knowing where to go when we need something, whether it's local university, whether it's the diaper bank that we have a collaboration with whether it's our local churches. Churches are big in the South for sure. Often we go to food pantries there. We just know where to go when we go there. We have a couple new partnerships, and we just as Kim said, we have a list, a mile long of agencies we've partnered with for years, but we get some new ones here and there. And most recently we have our diaper bank was a kind of a grassroots grassroots effort that just popped up from a local couple that saw a tremendous need in the area, and Safe Future Foundation, we partner with them, and the Florida Association of Infant Mental Health, we partner with that. We just partner with everybody that will help us in achieving all our collective goals, for sure. Maria, I don't know if you have anything else to add.
So we have about 5 minutes, and I'm going to pontificate for just a moment in a conversation that we had leading up to this, right before we opened up between us to kind of talk about, and I wanted to kind of lead with 2 examples. You know, we talked about the staffing crisis, and we talked about the shortage, and you know, nobody's getting into this to make money, right? We know this. We've all done this, and I was kind of, these conversations reminded me of my home visiting days, where, you know, you're fighting dogs and you're fighting nosy neighbors and you're fighting like all the things on top of having to do your curriculum and making sure that you're providing all these comprehensive services. And then also the ability, okay, so one thought comes to mind is not anybody could be a home visitor, right? We all know that that person really has to connect, just like not everybody can be a teacher, not everybody can be an office manager in the organization that it takes for that. I think it takes a unique person to be a home visitor. I think you have to have the ability to see the family for their strengths and who they are, and not always the situations that surround them, and the environment sometimes that they are fighting with and trying to survive in, and you guys are their best advocates. And I think a lot of home visitors get undersold in how creative you have to be, how warm and open and non-judgmental you have to be, and how loving you have to be. And so I didn't mean to go down this path, and I'll get teary-eyed on you guys, but what you do matters, and what you do is important, because nobody else, there's a lot of people. We could probably have a whole nother 3 hours of the stories we could all tell as home visitors. And Maria had an interesting story about this family that had to adjust course in the middle of it. Maria, if you would share, and then Kim, I'd love to end with your quote that you had. So Maria, if you could share with that, I thought that was a funny, not a funny, but you have to turn on a dime.
Yeah, so we had a family where the home visitor, she would visit the family just like any other family, and then one day she comes home and it's just dad and grandfather there. Mom's nowhere in sight. Apparently mom had some legal issues and had to leave, and so she, when the home visitor came, it was just dad and the grandfather. But dad and grandfather were not used to taking care of the children. They didn't really do any of the care, the nurturing, education, nothing like that with the children. So the home visitor had to do this whole shift on her lesson plans and what she would do with the home visits, because she basically had to teach the grandfather and the father how to change diapers, how to feed the children, how to bathe the baby. I mean, she had to literally start from scratch with them, until thankfully mom, like, I don't know, a couple months, or like, I think it was like 2 or 3 months after she was finally able to come back, after all the little problems and stuff that she had, she was able to come back, and they just kind of picked up right back where they were. But it's that kind of adaptability that you have to have right there on the moment to be able to handle what's going on with the families. And yes, especially through Head Start, we do have the education component that we have to teach, but that's where the home visitor and their adaptability kind of comes from, how to tie in what they're doing to the education piece that they're doing with they have to do as a requirement, basically. And then just how to be able to know all these different resources, because as a manager, yes, I know some of them, but they're the main ones out in the community. So I know they know way more than what I know. Even though I was a home visitor, things have changed over the years, and I know they're much more capable of knowing which resources they know. So
Thank you. And I think that gets to, Kim, did I cut you off? Were you going to say something? Kim Skirty?
No.
Okay.
No.
And again, I don't mean to laugh at that situation, Maria, but man, how many times have we gone into the lesson plan and we think, okay, not today. Today, we are going to focus on what this family needs, and we're going to just laser in on that. And so I love that story. And before I go to you, Kim Flowers, Pat says that she has 4 home visitors and just talks about the amazing connection between families. Absolutely. And And then thank you, Kim Flowers, for responding to Jessica in New Mexico with the 5 different counties and knowing where to go for everything. And then I would like to throw in that sometimes in one county, you know, the intake specialist for TANF or whatever might be really, really amazing and be able to give you great support. And then in another, they're overwhelmed and they have so many cases that they're just asking to fill out the form. So I think you're not only having to figure out what are the services, but you also have to figure out personalities and working around sometimes people being really overwhelmed. So we're at 3 o'clock. Kim Flowers, would you end us with your quote on the impact? And thank you all for being here.
So this is just one family, and the 13,000 that you were talking about, Katie. Oh my, and how can we grow this, right? This is one of our home visitors, perinatal home visitor, April of 2023. This is one of her monthly highlights. She says, I'd like to shout out Parent X for so many reasons. She's a returnee participant of mine, pregnant with her 2nd baby. When I met her 7 years ago, she was single, pregnant, and homeless, living at different shelters with no transportation and on county aid. She participated in our perinatal program and transitioned her son into early Head Start home-based, which they completed, and then he went on to kindergarten. She currently has a car, her own apartment, and just started online classes. And I just thought, oh my goodness, right? Like, think about the spacing, 7 years, right? And what that offers to a family, where we're having spacing between birth and where that parent was and what changed, right? And where they're at now with the new baby starting to launch and platform from this space now, if that makes sense, from a higher level of functioning. Yeah, beautiful work, just beautiful work.
Well, thank you all. We're so past time. And Maria Luna, Kim Skirty, Kim Flowers, thank you for your expertise. Thank you for your work. Thank you for jumping in and really helping us make this an amazing session. And thank you to all of you guys for being here. I hope you learned some ideas, and I would love to hear anything that you guys have going on. Have a beautiful day.